if I could say, I'm a thoracic surgeon. I do a lot of esophageal surgeries, which are food pipe cancers, where it's a relatively major, supra major surgery that it removes the food pipe extending all the way from the neck through the chest all the way down into the stomach. So you're actually operating in three zones. You're going to open three spaces along morbid surgery, and you're going to leave a lot of scars behind for the patient. So in this, I could safely say in the last 10 odd years of my practice, I don't remember having done an open esophageal surgery, because minimal access allows me to enter the entire rib cage, the chest, with three chopstick-like long instruments, which one of which is actually a camera, which is like my eyes inside the patient, and allows me to operate on the entire length of the food pipe, separating it from all the major structures, from the windpipe going to the lungs, to the heart, and the surrounding necessary, as we call it, clearance of lymph nodes, is all managed so comfortably with just a keyhole surgery. So I don't really have to cut open the patient so much. And there is a disconnection required at the level of the neck and the stomach level. So you take small cuts there, you complete the entire surgery laparoscopically and thoracoscopically, and the patient walks out with an organ completely replaced with hardly any scars. So definitely the rehabilitation, the recovery is expedited. So I am a proponent of minimal access surgery, and especially thoracoscopic surgery. VATS is my forte, and I'm very happy seeing that it definitely reduces the morbidity of patients after that. And I think where it comes to a choice, I would say also be very discretionary when you're using minimal access. Like I said, the same thing about a hammer and nail. So just because I'm a robotic surgeon or I'm a minimal access surgeon, and there's like a rock of a tumor sitting there, which is probably stuck to the bone, and I just want to be, really brave and boastful of it, that I removed such a large tumor. Even that I did with a minimal access surgery. I think somewhere there we've got to be very discretionary about that, and that is where minimal access gets a bad name. I have this common misconception which I'd love to get rid of in this conversation, is that a lot of patients would come to me saying, "Sir, मेरा operation open करो. Please don't operate on me with minimal access, because उसमें आप tumor छोड़ दोगे. Like, you don't have a good enough space to see, and you won't be able to remove everything." So the interesting fact is that the camera that we put in, when we use to do a laparoscopy or a minimal access surgery, has a 20x magnification. So I'm actually seeing things 20 times higher resolution when I'm doing it with minimal access. And I'm actually, technically, my eye is sitting inside the patient's body. It's at the tip of the scope that's there inside. So I have only a better view of it. I have limited range of movement because of operating through a keyhole, but the dexterity is very well managed with the excellent vision that we have. And that dexterity of the instruments is again taken care of in robotic surgery. So that's the added advantage of robotic surgery. So I would definitely say, don't have these misconceptions and leave the choice of what is best for you to the surgeon with his comfort zone and his discretion. If it's robotic is right for you, like I wouldn't encourage any prostate cancer surgeon to go through surgery without robotic, because that is the gold standard today. It's where we have the maximum benefit. But I would find it criminal if I was to have patients going through open esophageal surgery, because the morbidity is very high comparatively. So it's not like Robocop's operating as in we've just handed over the patient to a robot with a program punched in to get rid of his colon or his prostate or something like that. It's purely a computer interface that is between the surgeon's hands and the patient. So the arms of the robot go into the patient, but the control of those arms is actually on the fingertips of the surgeon. We actually wear rings on our fingers which control those instruments at the console. So the computer interface has a huge amount of benefit, as in even any human being has some intention tremors. So even those tremors are buffered because of the computer interface. So you're actually improving the precision of already an expert surgeon. So thereby it is actually improvising the surgical skills of the surgeon. And It adds to the comfort zone because of the three-dimensional. It's like you're watching a 3D movie. So everything's being done by the surgeon.